And my name is Lawrence Harding. I'm a physical therapist based out here in New York City. I've been practicing for over 30 years. More than half of that time actually has been working with people with spinal cord specifically, although I'm a big neuro head, so bring on all of the other neurological diagnoses. I'm very, very happy and comfortable working with them. But specifically for spinal cord injury, after working this long in the field, I was able to develop a technique called Spinal Mobility, which I'll be very happy to show you as components of this presentation. It's a separate technique in itself, but it's specifically geared to help people with neurological problems, spinal cord injury, people with MS, people with CP, even people with CVAs. It's geared to help them regain maximal trunk control because of their neurological injury. And it works for very many different populations. And for spinal cord injury, really works well for those people at the tetra and at the paraplegic level. I've been fortunate in being able to teach at Hunter College. I'm an adjunct faculty there and deliver the technique there. But I also do lectures at Columbia University, at Stony Brook University here in New York City. And I've been fortunate and grateful to present the technique in several ways at the Asia and at the ASCIP conferences in America. Additionally, of my time as a therapist, I was fortunate in getting together with these three amazing people: Yannick Benjamin, who's a sommelier here in New York City; Alex Elagudin, who's an activist also here in the city; and George Gallego, who's been very active in George's case with housing for people with disabilities. And Alex has been very much about accessibility, having just left the position of the disability coordinator for the whole MTA system here in New York City. These three gentlemen came together many years ago in the early hundreds of 2010, 2011, and created an organization called AXIS, the AXIS Project. And I was very fortunate in being part of the group to create the project, which is a community-based post-rehab multidisciplinary center for people with all kinds of disabilities who are living now post-rehab in the community. And the center is a place where they can come on a daily basis, 5 days, 6 days a week, and get community, get activities that promote their fitness, get activities that promote the communal aspects and socialization, get activities that encourage them to take care of their personal health. We have specifically assigned trainers who help people during their activities, especially for fitness. And in AXIS, we also get to do a lot of fun activities, adaptive sports, which there are a good number here in New York City, specifically like adaptive rowing. We've got adaptive parachuting. There's an adaptive surfing program that happens in the summertime. And it allows people with disability living in the community to maximize their quality of life. The AXIS project also gives me as a clinician an opportunity to bring in students from different programs throughout New York City to do this special X class. It's like an 8-week boot camp, and people with disability, in this case spinal cord, come in. We give them pre and post measures and then take them through this 8-week program to again teach them how to exercise and also help them attain specific functional goals like transfer improvements or functional reach improvements. And so the AXIS project has been really important in my life to help me continue to work with people in the community who have spinal cord injury and other disabilities. We're here today to talk about respiration and specifically how standing and performing respiratory activities can really boost function for respiration in people with spinal cord injury specifically. To do that, we're going to run through the physiological and pulmonary benefits of getting into standing in the first place. Why do people with spinal cord injury benefit from being in an upright position? We'll also talk about the anatomical and biomechanical, the neurological systems that go into creating respiration for humans, especially also talking about how it affects people with spinal cord injury and the disruptions that occur with that injury. We'll be looking at tools and also trainings to help people improve their respiratory function, specifically isolating inspiratory resistive muscle training, or IMT, that helps people to improve respiratory function for strength and activity, but also helps people to clean out, to manage their pulmonary toilet. I love to use that term because it's this idea of cleaning out the lungs to keep them maximally functional. We'll be looking at IMT programs and different breathing activities to be done while standing. And then finally, in the last section, we'll be talking about stretching activities. Remember, the rib cage is a cage, but it's a flexible rib cage. And with our population of people with spinal cord injury, especially at the tetraplegic level, they often lose the ability to mobilize the rib cage and maintain its flexibility and also maintain the volume that can be fit into the lungs. And so keeping strength to move the rib cage in its maximal function and keeping flexibility of the rib cage is as important as knowing what breathing activities or respiratory activities to be performed. So let's go into, firstly, the benefits and precautions associated with standing now for people with spinal cord injury. And we know those. We assume that people with spinal cord injury, assuming they can tolerate the upright position, will be able to get into a standing position. It helps them to change their alignment, especially if you look at trunk alignment, if you look at lower extremity alignment at the hips, at the ankles, and at the knees. It helps also to decrease the effects of constant sitting and of static hypotension that arises from not changing your position relative to gravity. Standing also helps with cardiac function by allowing the blood to pool further down and increasing the activity of the heart, of the whole vascular system. We can encourage and strengthen the cardiac function of people in a standing position, especially people with spinal cord injury. We know that standing can also potentially help their pulmonary function and their pulmonary toilet. And in addition to cardiac function, we'll be going deeply into pulmonary function. Otherwise, we also know that getting on a regular standing routine absolutely helps people with their bowel and bladder function. It's very much like when you know the idea of a constitution and ambulation helps bowel and bladder function. Similarly, standing in people with spinal cord injury does absolutely help with those two functions as well. And finally, socialization and quality of life and people's mood and affect get improved by participating in a standing program on a regular basis. One of my friends, when I first started working with people with spinal cord injury, told me, you know, Lawrence, all day I'm sitting at people's butt level and that's all I ever see. And it's hard for me to catch people's eyes because I'm not standing up. And so the ability to get into that upright position standing really does allow people to look people in the eyes during social situations, work situations, and just wanting to see above the crowd in crowded situations as well. So good benefits, eh? We also know that we have to watch out for these precautions that can turn into absolute contraindications depending on the degree of the problem. Orthopedically, we want to make sure that we have enough range of motion to allow that person to come up into the full standing position. And when we look at the tightness, either for joint tightness or muscle tightness, we really want to make sure that we are stretching the right thing and we are actually going to stretch things out. If you're dealing with a tight muscle that is totally contracted, you cannot stretch a contracted muscle out. If you're really looking at a joint that has become totally either orthopedically, skeletally fused, or the joint capsule is so super tight that you cannot stretch it out, you have to accommodate those limitations rather than try to correct them because you will not be able to correct them. Orthopedically, you should also look out for low bone density in people with spinal cord injury. We are aware that a lot of bone density is lost during the first year or two post-traumatic injury, and things may stabilize after that point, but it's still, in my head, good idea. If somebody comes to me and says, I want to do some standing activities, I've been injured for, say, 10 years, I'll ask them, when was the last time you were actually standing up? If it's anything less than 2 years ago, say they have been injured for 10 years and they haven't got up in the last 2 years, I'm going to ask them to just check with their medical doctor just to rule out any problems with bone density. Bone density in the trunk and also bone density in the long bones of the lower extremities. You want to just be sure. You can use a DEXA scan to check for bone density. Neurologically, these are the precautions you should really worry about. You will have to think about issues of hypertonia. The tonic display that somebody has when they're sitting down can be very different from the tonicity they experience when they get into the upright position. And so you want to understand how things change, either for hypertonia, or if you're dealing for somebody with, say, with a high level of injury and say they have subluxations going on in the glenohumeral joint, you want to know when their hypotonia needs to be supported and or invigorated. We have things we can do to reduce hypertonia using lower extremity FES bicycles or motor med, those kinds of activities, or just passive ranging before getting into standing can help that hypertonicity. Autonomic dysreflexia is also possible for people who have an injury at T6 level or higher. You should definitely make sure that your patients understand their symptoms and the signs of autonomic dysreflexia so they can alert you to look for the causes of this dysreflexia before they get up into standing, or if they're in standing and they feel dysreflexic, then you have to know what to look out for. Typically, we're talking about kinks in drainage lines and tubes. We may be talking about pinched toes in their shoes that can get exacerbated when you put pressure into the shoe. It could be a lack of proper alignment of the ankle, and the knees may experience overpressure. But if you look around, usually you can find the trigger or triggers for that autonomic dysreflexia and do something about it. You definitely want to fix that before people assume the full standing position. The cardiopulmonary limitations and precautions that you want to deal with include, of course, we mentioned orthostatic hypotension, and we'll be talking about different techniques we as clinicians have to work with orthostatic hypotension. We'll be talking briefly about hyperventilation, because sometimes people can get a little anxious as they come up into the standing position. Tachycardia and abnormal breathing patterns can also occur when people with spinal cord injury come into the standing position. So again, if it's your first time with this person, you can monitor these issues and keep track of what that person is feeling and go with their symptoms. Finally, in terms of precautions, more rarely contraindications, but definitely getting up, especially the first few times for people with spinal cord injury, especially traumatic spinal cord injury, it can be an anxious or a depressing event. You know, anxiety because I've not been standing in 6 months since I got this injury. I've forgotten what it's like to stand up, or depression. Oh, this isn't really standing like I used to stand up. It's actually standing in this funky big machine. And so preparing your patients for their emotions before they get up into the frame, just a little conversation is never a bad thing. Let's go into the anatomy of the structures that produce respiration in people. Number one, of course, is the thoracic cage or the rib cage itself. As I mentioned, it's a flexible cage comprising of the ribs, the spine, and the vertebra in the back. And then in the front, you have the lock into the xiphoid process, the body of the sternum, and then the manubrium at the top. Please remember, when it comes to the rib on the right over here, you have your true ribs and your false ribs. The true ribs are the ones which go from rib 1 to rib 7. They're true ribs because the ribs up to 7, as I said, insert directly into the sternum through these costal cartilages. Each one of the true ribs has a direct costal cartilage from that rib to the sternum until rib 7. Ribs 8 all the way to ribs 10 are actually false ribs in that they don't actually directly link to the sternum through their own costal cartilages. The ribs 8, 9, and 10 link to the costal cartilage of rib 7, and that's how they get attachment to the sternum. So they are not true ribs with their own direct connection. They are false ribs. Ribs 11 and 12, even though they're also false ribs, are truly called floating ribs. Because if you look at this back slide from the back view, you can see that ribs 11 and 12 don't actually have any costal interaction with the sternum. There are no costal linkages and cartilages, even through the other costal cartilages. They are truly floating ribs. They are not floating around, just banging around in your body, because they serve as really important attachments for muscles and fascial bundles that attach through different structures up into the rib cage. And so they are very important in respiration, even though they're technically floating ribs. I put this slide in here primarily just to give you all a good impression about the way that the ribs angle downwards. They hang in this down position. That's their normal resting place. And during respiration, the rib elevates. You get a bucket handle movement where the rib cage actually lifts up forwards in the frontal plane and also expands sideways in the sagittal plane. But in the resting position, you see that the bottommost rib 12 here is actually at the level of L2. We know that the pelvic crest, the iliac crest, comes up to the level of L4. So really, in full upright position with good posture, there's not a lot of space between the bottommost rib and the top of the iliac crest. It's actually a fairly short distance. You can put your hands there and see how little space there are. So if you're thinking about people now in spinal cord injury, say they've been injured 5 years, 10 years, 15 years, they may have some kyphotic issues going on because of prolonged sitting. They may have some scoliotic issues going on because of a muscle imbalance or just because that's the way their body's collapsing. And so any change or loss of mobility here can cause the ribs to literally just bang down and hang out, banging down onto the iliac crest. And so you want to be aware of where those limitations in not only the position of the rib cage, but its movement relative to the iliac crest. When we talk about movement of the ribs, we of course have to start talking about the intercostal muscles that go between each of the ribs. There are 3 sets of muscles. As in the abdominal wall, you have 3 layers that make up the walls of the thoracic cage. The external intercostals go from rib 1 to 11. Internal intercostals go from 2 to 12. And the innermost intercostals are the same level as the internal intercostals, but they really only comprise a small section of the ribs, as I will show you in the next slide. So looking again at this slide, we have our external intercostals that do girdle fairly amount all the way around the thoracic cage. You've got your intercostal muscles underneath that. And then underneath the intercostals, you have your innermost intercostals. Note that the direction of the fiber pull of the external intercostal is directly opposite to the direction of fiber pull of the internal intercostals, because as you will see, they do very different things. The neurovascular bundle, there's a main one that exists between the internal and the innermost intercostals, and there's also a small little collateral group at the bottom of that space. And they innervate those muscles as motor nerves. It's interesting to look at the kinematics of the intercostals, because as I said, the fibers of the external and the fibers of the inner intercostal run opposite to each other, because as you can see, when the external activates, it elevates the sternum and it lifts up the whole rib cage. On the other hand, contrary, when the internal intercostal muscle activates, it pulls down the ribs and it closes up the thoracic space and closes down into the thoracic rib cage. Note that the fibers of the external intercostal not only run perpendicular to each other, but the fibers of the external intercostals run in the same direction as the fibers of the external abdominal obliques. They all do the same thing. And similarly, the fibers of the internal intercostals run in the same direction as the fibers of the internal abdominal muscles. And so you'll start to see this symmetry between what happens in the thoracic cage and what happens in the abdominal cage, in the abdominal space as well, in terms of activation of the muscles. And we'll be getting some nice pictures to look at how those 2 spaces interact with each other, especially during forced exhalation. Moving on, let's look at the diaphragm now. The diaphragm is the main muscle, and it is a bigger muscle. And I was thinking about this today, and I see one of the problems with the diaphragm is the diaphragm does not really have an antagonist. Think about that. But it's shaped like a parachute. It's normally in this up parachute position, and then when it activates, the diaphragm actually drops down and flattens out into the flattened diaphragm position. There are many, many attachments to the diaphragm, all the way up to the occiput on the spine, through the back and the rib and the vertebra. But it also inserts below through the L1 to L3 vertebra, and it inserts through muscular connections from itself to the psoas, to the quadratus, things that we already talked about briefly, and we'll go into more detail. Transversus abdominal is linked to the work of the diaphragm. By fascial connections, we know it attaches to ribs 11 and 12, remember the floating ones. And it also has strong fascial connections to a lot of the organ systems in the abdominal cavity. The GI system through the intestines, the cardiovascular system through the aorta and the blood vessels. The liver is attached through fascia, kidneys, and all the way down to the pelvic floor. So lots and lots of attachments. The muscle, as we know, 3, 4, 5 keep you alive, and those are somatic nerves that come down from the respiratory center to innervate the diaphragm and the external intercostal muscles for inhalation. There are muscles inside the rib cage and other muscles on the backside of the rib cage that help to maintain the structure of the rib cage as the intercostals change the whole shape of the rib cage. And so these smaller muscles, although not primary movers of the ribs, do help to support, maintain, and direct the shaping of the ribs as the ribs do their own activity for respiration. The first one we'll talk about is the transversus thoracis. It is located on the inside of the ribs now. So next time you're cutting up chicken, when you open up the rib cage, look inside, you might see evidence of that muscle. I'm not too sure it exists in chickens, but it is there in humans. And its origin are around the 4th to the 7th rib, and they insert directly into the sternum, and again, help to keep the shape of the ribs during respiratory activities. Another intrinsic muscle on the backside, but on the inside of the ribs now, are the subcostal muscles. These are short ribs that exist at 2 or 3 levels, and then you have another pair 2 or 3 levels down, another pair 2 or 3 levels down. And their action is to depress the ribs during forced exhalation and also support the shape of the thoracic cage during respiratory activities. There's a third smaller set of intrinsic muscles attached to the rib cage itself, called the levator's costarum. They are 2 pairs, a short pair, the brevis, and the long pair, the brevis, that exists all the way from C7 down to T11, all the way down the ribs. And their action is to elevate the ribs during respiration, as you can see, and during forceful respiration at that. We know about the accessory muscles of respiration, especially with spinal cord injury, because people with higher levels of injury at the mid to high thoracic level can use them for increased respiration as necessary. The scalenes and the SCM sternocleidomastoid are the 2 muscles. We'll talk about the scalenes first. There are 3 of them. The anterior scalenes, middle scalenes, and then the posterior scalenes. Of course, there's one on either, there's a pair either side of your neck. And so all of those muscles, there's anterior scalenes insert into the first rib, as you can see. The middle scalene also inserts into the first rib, but the posterior scalene inserts into the second rib. So their action is to help elevate the first and second rib, which will then pull up the rest of the thoracic cage during forced inhalation. On the other side, you have the sternocleidomastoid, which similarly not only does truncal movements and spinal movements and head control, but also because you have the manubrium connection and the clavicular connection, the SCM can also act to elevate the rib cage during forceful inhalation. We can't talk about the scalenes without talking about thoracic outlet syndrome, especially for our population. We have people who, again, are sitting not necessarily always in a most open, neutral position for the spine. They often are sitting in that slump position and tend to be a little bit more internally rotated, a little bit more scapular protraction, and all of that action and those positions can certainly cause changes in the alignment of the scapula, the alignment of the clavicle, and the alignment of that first rib, because you have the brachial plexus that needs to go down into the arm, and that needs to pass between the anterior and the middle scalenes. The subclavian vein has to pass from the subclavius muscle right here and underneath the anterior scalene. If there's any kind of pinching of those scalene muscles, either from overwork because they get hypertrophic, or from overwork because now you have a little bit of a scoliosis going, so one side can be a little tighter than the other side, you can end up with thoracic outlet syndrome. So please note that there are 3 different places where that neurovascular bundle of the brachial plexus and the subclavian artery and vein can get pinched. Most proximally up here, you can get a pinching of the bundle of the brachial plexus as it comes from the anterior to the middle. And that generally is called the scalene triangle compression. People can also refer to it as scalenus atticus. But you can secondarily get pinching down here at the costoclavicular junction, where the bundle, the whole neurovascular bundle, goes underneath the clavicle. And you can see if a person has a hypotone, where the clavicle just drops down, or if they have a lot of tone where they're elevated in the clavicle and the ribs underneath it, the first ribs gets pitched up into the clavicle, you can end up with a situation where you get pinching at the costoclavicular junction right here. Finally, a third possibility of tightness and pinching of that neurovascular bundle occurs down here in the interpectoral space, wherein the pec muscle, again, internal rotation, slump forwards, the pec minor can get quite tight and pinch on those nerves and blood vessels as they come underneath the pec. You can determine that it's thoracic outlet syndrome by looking at the location of pain and also determining which of these 3 separate areas you're getting pinching at, because specifically up here with the scalenus atticus, you will get neurological signs, tingling, pain, but you will not get the vascular signs that you get most clearly when you get some of these lower aspects being pinched. You can check the vascular sign with your thoracic outlet syndrome by palpating you can take the radial artery, you can palpate the radial pulse and see if it gets diminished as you go into the tight position. So we have tools to assess for thoracic outlet syndrome. Apart from those primary movers of the ribs, we also have positional muscles from the scapula that help to position the whole scapula, the first ribs, the clavicle in a good place for respiration. We are very familiar with those scapular positioning muscles, especially for people with tetraplegia, because we rely on them so much. But the trapezius is going to be active, and we know that people with high levels of injury tend to be very overactive in their upper traps. And so working the low traps to strengthen the low traps, which exists for people with all levels of spinal cord injury, is a really crucial aspect and the crucial muscle activity to keep the opening of the whole thoracic cage. Our rhomboids are very, very important. And so again, if somebody's been sitting in that rounded forward C position, their rhomboids are going to be very, very weak and overstretched. And so they may not be able to position the scapula and hence the thoracic cage in its optimal position for respiration. We have the levator scapula, similar to the upper traps, which can cause an over tightness of elevation in the scapula. The serratus, like the rhomboids, when you're in that C position, can get quite stretched out. And so weakness will prevent the scapula from being put into that right position where the serratus can help stabilize during respiratory activities. And finally, again, we talk about the pec minor and how tightness of the pec minor can restrict rib mobility, especially for respiration and exhalation. There are back muscles that assist respiration. We have on the right-hand side, the second layer of our back muscles comprise the serrati posterior. Serratus posterior superior is up here, and serratus posterior inferior is down here. And if you look at them graphically, we can see the lines of serratus posterior, which come up to ribs 2 and 5, and also attach to the scapula here, can also help us to elevate the ribs in the back. Superiorly, that's what they do. The inferior ones, which go from the nuchal line again, and the low thoracic to lumbar vertebra, and insert on ribs 9 to 12. As you can clearly see, they can help depress the ribs and move them posteriorly during forced exhalation. It's nice to see the relationship between the serratus posterior superior and posterior inferior. Look at how the superior works really, really nicely with the levator costarum muscles and how they can all work in concert to create nice elevation of those ribs during inhalation. And think about how quadratus helps to, we'll be talking about that in a second, helps to activate the 12th rib during inhalation and exhalation activities as well. And it's just beautiful symmetry between those groups of muscles. You have the iliocostalis as well, a big lumbar erector spinae muscle that we think only of as trunk mobilizing, but they do also iliocostalis specifically insert into the ribs. All the way up to C4 transverse process, you have iliocostalis inserting all the way back, all the way up there. Lumborum goes to L4. Iliocostalis thoracis goes to the ribs 1 all the way down to 6. And so they can actually help during forced exhalation by depressing the ribs. Quadratus, finally, to finish with the last back muscle that activates into the ribs. It fixes onto the 12th rib. Quadratus's function is not really to move that 12th rib. Remember, the 12th rib isn't attached to the rest of the rib cage. It's a floating rib. But because it has connections to the intercostal muscles, what happens is when quadratus lumborum activates, it stabilizes the ribs, because you don't want the whole rib cage to move upwards. You want the rib cage to accordion open. So something needs to hold the accordion down at the base. And quadratus is one of those muscles that holds the base of the thoracic cage while the rest of the thoracic cage gets elevated by the external intercostals and by the action of those secondary muscles if necessary. And so you need something to hold the bottom of the accordion while the top expands upwards. And that's quadratus. There's another muscle that helps quadratus in that, which is when you come to the front. The abdominal muscles are all about forced exhalation. They do not participate in inhalation at all. We'll get into that when we talk about the mechanics of respiration, but they are all about forced exhalation, and we know them well. The internal and external oblique abdominal muscles cause depression and closing down of the abdominal wall, and also thereby push a relaxed diaphragm into the up position and therefore help with forced exhalation, coughing, laughing, singing, yelling. And so does the transversus abdominis, which is actually more of a girdle, but its function again is to cause contraction of the abdominal cavity and slight depression of the ribs to which it is attached. Finally, in the front, we have the abdominal rectus abdominis. And like the quadratus, the function of the rectus is to hold down the ribs so that the elevation can occur at the top end from those elevating muscles like the external obliques. It inserts all the way down to the pubis and inserts directly onto the xiphoid process and those bottom 5 to 12 ribs. So it has this ability to really lock things down. So that's pretty much all your muscles as far as respiration and as far as assistance for positioning for respiration is concerned. However, we couldn't talk about pelvic positioning, about truncal positioning, spine positioning, if we don't talk about the pelvis. Of course, we understand the pelvis is important. Positioning the pelvis when one is sitting is important, but tonality changes, alignment changes. Maybe there's a leg length discrepancy that may not be observable in the sitting position, but everything changes when people get up into the standing position. So please be aware of the pelvis when a person is in standing. If they're too anterior tilted, you get too much lordosis in the lumbar spine versus too posterior tilted where you get increased kyphosis. Do you have an obliquity going on? Are these obliquities and positional differences, are they fixed? Should they be accommodated otherwise? Can they be strengthened or put into place with the right kind of padding? So you absolutely shouldn't just concentrate on the thoracic cage and the scapular girdle above. Please look at the pelvic girdle below, because it makes a big difference. Let's get into the mechanics of exactly what takes place. Now that we know the anatomy, we know the muscularity, and we know what does what, let's talk about what does what. Restful respiration is active for inhalation, but it is a passive recoil action for exhalation restfully. So during inhalation, the diaphragm is activated through the phrenic nerve, right? The diaphragm goes from its high parachute position, it drops down into the low parachute position, it pushes down on the abdominal contents, and the abdomen actually pushes out a little bit, okay? As it pushes down, you also get activation of the external intercostals. The external intercostal muscles get somatically activated, and they then elevate the ribs slightly. You get this expansion and opening of the whole thoracic cavity because the diaphragm has descended, the ribs have opened up, the pleural pressures change, and the lungs passively get filled with air. It's passive issue respiration. It's because of that pressure difference between the pleural cavity and the outside air. Air just gets pulled in. For exhalation, it's passive. So all that happens is the diaphragm relaxes, it goes back into its up position, the external intercostals relax, they go into their down position, and both of those actions decrease the volume of space and increase the pleural pressure in the pleural space, and the air literally just gets pushed out of the lungs. So purely active for inhalation and passive for exhalation, restful respiration. Now, when we talk about forced exhalation and inhalation, on the inhalation side, we know that we bring in the muscles, including the sternocleidomastoid and the scalene muscles. Those two are very crucial for inhalation. The regular muscles of the of the external intercostals and the diaphragm continue to do their work, maybe albeit a little bit more forcefully during forceful inhalation. For forceful exhalation, the big guns come in. Your intercostal muscles, your internal intercostal muscles, which are at rest during restful respiration. They don't work during normal restful breathing. During exhalation, forced exhalation, your internal intercostals close down and they depress the ribs to cause closure of the thoracic space. And then finally, for forced exhalation, you bring in the abdominal muscles, which close down on the abdominal wall, causes pressure to build on the diaphragm, which is now relaxed, and the diaphragm gets pushed up and forcefully closes off the thoracic space, and you get a cough or a breath to take another big breath in before you take the next step. And I love this slide primarily because it shows us all the direction of pull of the muscles. The diaphragm is pulling down for inhalation. The ribs are getting pulled up because of those external intercostals. And then at the top, when we have the accessory muscles kicking in, we have the sternocleidomastoid and those scalenes kicking in on the left-hand side, all to pull everything upwards. On the right-hand side of the slide, for forced exhalation, we have the, my finger slipped. On the right-hand side, we have the forced exhalators coming in, the internal intercostals, and we also have the abdominals kicking in to close off the abdominal space. And those are your two major groups of muscles for forced exhalation. But another reason I like this slide is because up here, we have the action of pec minor. Now, we didn't introduce pec minor as a muscle that is really part of respiration, but it is. How do we see this? You know, if you're watching, especially athletes or anybody who's done a really, really stressful activity, at the end of that 100-meter dash, what do? They either will fix themselves on themselves, you know, they walk around and their hands are fixed on their hips, or they'll find a wall and they'll lock into a wall, they'll find a stable object and they lock their upper extremity onto that stable object. Why do they do that? Because Once you've got this close chain action of the pecs and the pec minor included, then the pecs can become secondary muscles of respiration because they can also assist, as the picture indicates, to help with forced exhalation because they'll really lock down on those ribs during forced exhalation and allow you to really get the breath out. And so pecs come in a lot during exhalation. Remember what I said about inhalation? You need something to lock, to accordion. So during inhalation, the abs lock down, also quadratus locks down, and so you can get this nice opening of the rib cage. Same thing here. If the pecs are pulling up, they're locking up so you can lock down those ribs and really close off the rib cage. And so you have this opposite effect of the pecs on one side and the quadratus and also the abdominals on the other side, helping to control the extent of this opening or the extent of the closing of the rib cage. Really amazing construction, right? Neurologically, how do we get control of our respiration? And this will take us nicely into how people with spinal cord injury get affected and their respiration is limited. So our neurological control of respiration starts up in the brainstem between centers in the pons and centers in the medulla. Information, sensory information gets pulled into the left here from all of these structures, from the carotid artery and the carotid chemoreceptors, from the lungs themselves and indicators and receptors that tell us about the carbon dioxide volume in the air itself. In the blood, we want to know about our carbon dioxide in our bicarbonate levels. We also want to have input from the higher centers, from the brain. What are we actually doing when we're breathing? Does the brain have any part in that? We breathe when we're emotionally, we breathe differently if we're in an emotional condition versus in a happy position. And so all of these higher centers can affect our breath. Also, you want to think about emotionality. How you smell some old memory is very different from how you smell something bad. And so emotions come into play with our breathing as well. Muscle activity comes into play because if the muscles are burning up all of our O2, the breathing center, our respiratory center, wants to know what the muscles are doing so that we can activate the right level of breath. The breathing is automatic, as I've been saying. It's rhythmic, it's centrally regulated, even though we do have some voluntary control. And there are all these organs that send information. If you look to the right here, the two main outputs are the phrenic nerve, 3, 4, 5, and also those motor nerves that come through the spinal cord, but activate somatically the external and internal intercostals for respiration. If you look a little bit more deeply into the neurological control of respiration, you can see that you have these medulla centers, and then you have your pons centers. The medulla centers are these two, the dorsal respiratory group and the ventral respiratory group. The dorsal one is the main player. That is the main central pattern generator. It gets input from this apneustic center up in the pons that receives higher information from the brain and the thalamus, for example. And so are we singing? Are we talking? Are we laughing? The apneustic center will regulate what the dorsal regulatory group does. In cases of stressful activity or stressful need, the dorsal respiratory center will send information now to the ventral, and it's the ventral respiratory group that affects the secondary muscles of respiration and the internal intercostals to kick those in for deep breathing. Finally, up here, this pneumotaxic center, its role is to turn off the dorsal respiratory group, which I think is such a smart idea. Because when you think about it, the diaphragm does not have an antagonist. Okay, neurologically, when the agonist works, the antagonist is automatically inhibited. The diaphragm needs inhibition so that you can talk without your diaphragm being activated, so that you can cough without your diaphragm being activated. And so the pneumotaxic center is really the off switch for the dorsal regulatory groups on switch. And so you have this nice on and off control mechanism built into the center. If you now talk about how does this all affect people with spinal cord injury and their respiratory access, people with C4 up to T11, all the people with tetraplegic injury, they have no access to their intercostal muscles. They only really have access fully to the diaphragm. Think about that. You need to get to T11 before you start getting access to those intercostals. And they, as we know, come in segmentally. So if you're T4, you only have intercostals to T4. If you're T6, you have intercostals to T6. And it's really only when you get to T7 that your abdominals kick in. Abdominals do not kick in at T4. And so when you think about forceful coughing, forceful exhalation, people with a T2 injury have a limited amount of forceful exhalation they can really perform. And this will affect the pulmonary function. And this slide is just another way to really look at all those different levels. High tetras, what do they have? Low tetras, what might kick in? Their scaling start to kick in, and so on, down all the way to the people who at the low power levels, T7 and lower, they are the ones really who can access their abdominals. Because of this variability in the level of innovation, you can get some different ways of breathing. Normal breathing is inhalation, and then the rib cage, the thoracic cage rises. The diaphragm also gets risen because of the passive push down of that flattened diaphragm as it pushes into the abdominal contents, which then cause the abdominal wall to rise. During normal respiration, they both go down. When you have issues with spinal cord injury, the one thing that you want to watch out for is this to the left, paradoxical breathing. Because unlike normal breathing, in paradoxical breathing, when the chest wall expands, the thoracic cage goes up, you get an inward pull of the abdomen, and that should not occur. That's a problem. That's a medical problem. It might be a hole in the diaphragm. It might be some atelectasis going on in the lungs. There's several respiratory reasons that this is occurring. So if you see paradoxical breathing in somebody who's supine or even sitting down, you really should get medical in and alert somebody so they can be assessed and treated. Ribcage breathing may simply be because somebody's breathing really shallow up here, and diaphragmatic breathing could be useful in terms of getting air all the way down to the lungs. So those are not truly abdominal, but normal breathing is normal breathing, right? And again, just to make sure that you can see paradoxical breathing, look out for it. You will see it if you're working off with people with spinal cord injury. Quickly reviewing those benefits. We're talking mainly about the orthostatic issues that we want to help use standing and breathing to help reduce those effects, cardiac function, and then the pulmonary function in toilet. Orthostatically, we have tools, medical, pharmacological interventions like midodrine. We also have non-pharmacological interventions that we clinicians can use, the tilt table, the inspiratory respiratory muscle training, we'll be talking about those too. And then of course, you can always use FES. For example, if you put somebody on a motor med, it's a passive and active assist bicycle that can definitely rev up their blood pressure a little bit and reduce the effects of orthostatic hypotension before they get into the standing frame. And there is evidence from Harkimer in Louisville that's telling us that standing body weight supported activities can also help people with spinal cord injury to increase their blood pressure and reduce the effects of orthostatic hypotension. If you are going to be using a tilt table, there are protocols in place and steps you can use. The key to take away from this is check their vitals frequently and with every position change of the tilt table. Even if you're going straight into standing frame, if the person hasn't been in standing frame for say 6 months, 9 months, it's not a bad idea to check their vitals during, say before, during, and while they are up in the standing position. For standing in general, the dosage recommended for all forms of standing should be at least 30 minutes to 60 minutes a day for 4 to 5 days. Less than that, really, you're not really allowing yourself to get all the best benefits from standing. As I mentioned in the previous slide, if you're going to have people with spinal cord standing, you really need to encourage them to use compressive garments. Compressive stockings in their lower extremities is usually very useful. is very useful, I should say, not even usually. Because the bigger problem is the pooling of the blood over prolonged standing down because of the gradient, the gravity gradient. And so having graduated compression stockings can help to pull the fluid back up. And these can be lightly graduated with light pressure, 15 to 20 millimeters of mercury. Class 2 has 20 to 30 millimeters of mercury. There's a firm class 2 that's 30 to 40. And really, by the time you go above 40 millimeters of mercury, that's a lot of compression. And most people do not like and cannot tolerate that level. So between class 1 and class 2 type of compression garments, those are the typical ones you'll find out in the market. And those are what people generally will use for their standing activities. Please note, like everything in life, shoes, pillows, bodies, these things wear out. So if you've been using them rigorously for 6 months, you do need to change them. Do not confuse compressive garments with TED stockings, please. Just a small little note to remind y'all, because TEDs are for thromboembolic deterrence. Okay, they're about DVTs. And unlike the compressive garments, their maximum pressure really does take place around the gastroc level, and it isn't a graduation from the ankle upwards. Their pressure is only between 8 and 18 millimeters of mercury. So we're dealing with less compressive garments, and they will not be useful for standing activities. Similarly, they don't last long, and they should be changed after about 3 weeks of use. Compression can also be obtained by using abdominal binders. Again, there's good proof that abdominal binders have the potential to help people with injuries above T6 with keeping their pressure higher than otherwise. And the devices could either be a plain stander or it could be a standing chair. There are lots of new standing wheelchairs out in the market now. So if you're going to be doing strength training for your respiratory muscles, we definitely want to start working on those activity and the somatic muscles that you have control of, depending on the level of injury that you have. And so this gentleman is Angel Martinez. I've known Angel for 7, 8 years. He was injured maybe about 10 years ago, and his level of injury with spinal cord is at the T11. So that's a lot of things that Angel has access to. I thought it would be useful because then you can see how maximally he can do these activities. If you're working with people with higher levels of injuries, they can perform some of these activities to the extent that they can, either because they have control or because they can overflow into some of these movements. And so you can always modify and tweak these activities for different people, depending again on their level of injury. And so in Angel's case, we can do some abdominal work because he is at that T11 level, and we want to get those abdominal muscles strong. He's pulling forwards. One more time, he's pulling forwards. I'm giving him light resistance and helping him to return to the upright position. Pull, and I help him back. In addition, we can also have him use his pecs. So now he's really pulling in those pecs and closing down into the action. So when he does that with exhalation, you can get a nice good opening with inhalation. Pull in. Gets the rhythm. Pull in, pull in, pull in, pull in. You can see a little bit of the spinal mobility technique in here because I often use the belting to help stabilize their pelvis so they're not just wobbling around in the frame. And I often use the disc in the back, one of those stability discs, to destabilize the pelvis so that the pelvis has something to work against, because everything is too stiff. There's no work being done. Moving on and looking at different activities. We can also include pure resistant band activities. It's a little weak for him, he's strong, but you can modulate it according to the strength of the person. And that's really great for their lats, for those posterior muscles that help to keep them nice and open. And pec activities as well, shoulder adduction. It's a nice dynamic activity. So when he comes back with the rebound, we can get maybe a little stretch of those pecs in the front. We can do shoulder girdle activities by helping people to come up above their hands. People with spinal cord injury do not tend to go above head very often because of the balance issues. And so in this case, Angel is doing a shoulder abduction and extension activity, and I'm giving him very mild resistance as he comes up, just pretty much helping him as he comes up. Again, I'm using the belting here to help stabilize him so he's not falling forwards when he returns to the down position. We have this sternal prop in the front, but sometimes you want to give them a little movement, and so rather than falling forwards, the belting helps to keep him nice and stable. This is a scapular depression. Those low traps in people with spinal cord injury, and most humans actually, they tend to be rather weak. And it's nice to do this in a standing position because now we have the whole length of the spine and of the trunk to work with. So you can really get that full action. We could also turn it into a side bending activity and getting those lats and side bending thoracic muscles to work. We'll do that, look at that one again. In this, Angel is holding on with his left hand, and so that's giving him a certain amount of stability. However, to challenge those muscles a little bit more, I can get him to go into this scratch position with his hand around his ear. So now he really has to work hard, and you can see the work on his face and how hard he's struggling to get himself to do the side bend activity. It's really efficient. And so, sorry, moving on. There are different ways that we breathe. We really do breathe in multiple kinds of ways. We breathe when we're singing. Coughing is so different from running. And of course, restful breathing, it's its own thing, right? And so when we do breathing activities, we want to try to challenge our breath in those different kinds of ways. Now, yoga, Tai Chi, martial arts have many, many breathing techniques that could be absolutely applied in this case. So please do not assume these are the only ways, just that these, again, functionally reinforce some of the activities that people do. Pursed lip breathing is really great if you have some kind of COPD or restrictive issues, because by pursing your lips when you're breathing, you try to maintain the alveoli a little bit more open. And so puckering and slow blow out. Bellows breathing, like the bellows you use to get the fire going. And so it's rapid inhalation and exhalation. Watch out for lightheadedness. So strength for coughing, strength for laughing, fast. Stacked breathing helps with the volume of the lungs. And so again, you're thinking, I'm taking a breath, a second breath, a third breath, and then exhaling, and then repeating the process. Diaphragmatic or segmental breathing is great because you can use your hands, or they can use their own hands, to direct expansion and opening up of different parts of their thoracic cage, especially the back. People do not breathe into their backs. They breathe all the way up here and all the way down deeply into the diaphragm. You want to encourage that. Sustained exhalation is like singing, taking a deep, long breath and letting it out as slowly as you can. Eccentric control of the diaphragm and the abdominals and all the other muscles that might be kicking in during that inhalation. You can bring in for 6 and 7. You can bring in actions with the arms, like we did with Angel. You can bring in forwards and backwards rowing actions, like you're doing a cycling or an rowing action. Again, a lot of our lives as human is very much on a table, moving arms backwards and forwards or side to side. We have tools to help all of this training. And why should we use these tools? Because of all these reasons. We need to maximize our pulmonary function, improve the work of the diaphragm for vocalization and respiration. We want to encourage maximal pulmonary function in blood and oxygen and carbon dioxide transfer. And here, clearing of secretions. Ultimately, to reduce the strain and the pain and the stress of breathing. Because for people with high levels of injury, just the whole breathing things can become quite fatiguing. And so helping to strengthen those muscles is really, really useful. We have different kinds of tools, starting from the simple at the bottom, free weights. I put somebody in supine, maybe in hook line, to relax their abdominals a little bit. Take a little heavy weight, 10 pounds, 15 pounds, 20 pounds. Put it right on their diaphragm when they're in supine, and ask them to breathe down into the diaphragm so they can lift and lower the free weights. Balloons. Give them a balloon to blow up. It's amazing how many people with spinal cord injury cannot blow a balloon. They just don't have that oomph to start stretching the rubber or the vinyl of the balloons. Straws. You can take 3 or 4 straws lock them in together, put one straw into the end of the other straw, make a 3-straw length straw, and have them breathe in and out of that. The small size of the cannula of the straws, the length of the straw itself provides resistance. It's cheap and it's fun. You can do it in standing. I have these straw games in people in standing all the time. Going to more specific tools like these trainers, we can use our resistive inspiratory trainer, and ultimately we also want to stress the use of the spirometer because that helps us to maintain our lung volumes. And so please make sure that when people are using the spirometer, they keep using it, because as soon as they're out of the hospital, people stop using the spirometer unless they really have to. And make sure that they're using it properly. The key step here is step number 3. We've seen people do the spirometer wrong, where they just kind of stick it in the mouth and they're just huffing and puffing away like a steam train. No. The third step, where you take a deep breath, and in holding that deep breath, extending that breath for over 3 seconds, they really are keeping the floater, the gauge of the spirometer in its best place. And you can see this gauge over here on the left on the volume, and over here on this air life. There is the gauge. And so that gauge must be where that little floater is resting during the inspiration. Most people do not regard that. And the technique is really important. Then you get the maximal volume of air in. For the resistive trainers, the P-Flex has been around for decades. And this Medline one is a new idea. But it's this idea that you are breathing in through different size holes and different apertures, and you can change the aperture, make it smaller as you get stronger. Here's the P-Flex again, and this is the schematic that explains. You can change the hole size, and that will change the resistance of the air as it comes in, and then you breathe it in, and then you breathe out without any resistance. I actually love the second kind, but the inspiratory muscle trainers do come in these newfangled smart ones where they attach to an app, and the app will give you a table. You'll have a recording, automatic recording of all your activities. And so if you want to keep track, these are good tools to help you keep track of what you're doing with your breath. The inspiratory threshold trainers now, they also come with resistance, but the resistance is built into a threshold level in that, looking at the schematics, when you take a breath in, the breath has to be of enough force to release this spring mechanism, and that's when the air starts coming into your lungs. And so you have to perform enough of a sort of suck power so that you can overcome this threshold before the device works. And so for certain activities like blowing a balloon, you need a certain volume of breath to be able to blow a balloon, or even blow or call across the room with enough force and volume to get across the room if it's a crowded space. And so the threshold trainers can take you places that the resistance trainers may not. Again, the idea that it is you taking good, strong, long breaths with these devices rather than just, it is not about speed, it's about depth and repetition, and also about resistance. And so your goal is ultimately to increase the number of repetitions and to increase the resistance of these devices. Mucus clearance is important for people with spinal cord injury. It's important for us, but we can move around and use our mobility to help clear out the mucus. Secondly, for those of us who are fully innervated, we do have full access to our abdominals, which are the main expirators. However, for people with high paraplegic injuries or tetraplegic injuries who may not have access to their abdominals with Asia B's and C's, for example, we do have tools to help them clear mucus when it builds up. I've used the flutter to the left. I've used the acapella to the right. And both of these devices, as you breathe in through them, they create a pulsation of the air waves, so to speak. That percussion vibration, when we do it manually, they create this percussive air wave into the lungs that then induces coughing and helps to shake up the ketchup a little bit so that then it can be passed up through the cilia. This is a newer device I have not used, but similar to those devices like the flutter or the capella that produce this wave automatically, this device also produces oscillations, but it does that with positive pressure, like with ventilators. And so that, again, assists in helping to mobilize the air inside the lungs and helps to clear out the mucus. The most effective but the bigger device is the insufflator. And those of you who work with people with high levels of spinal cord injury, say C3s and C4s, might have come across this device. It is a face mask. It provides both positive and negative pressure, and it can really force air in and pull air out to, again, maximize the clearing of the mucus in the lung systems. Very, very useful, and can certainly the PFlex, the strengthening activities and cleaning out activities can also happen in a standing position. You can do percussion vibration in standing, very effective, because now we've been in a place where you can really open up the thoracic cage. So it's good for a lot of different activities. I mentioned that we would finally be talking about stretching, and stretching, as I've been saying, is terribly, terribly important because we want to give people the maximum mobility, and not only in the extremities. You know, we're very concerned with stretching our extremities, the hands, the legs, but stretching not only the trunk, the lumbar trunk, but stretching out the thoracic cage as well. I keep saying it's a cage, but I also do keep saying that it is a flexible cage, and the degree of mobility of the rib cage is directly correlated with the volume of air and the effectiveness of one's breath. And so maintaining thoracic mobility, maintaining thoracic vertebral mobility is really, really useful. We know that muscles only do one thing, they pull. Remember what I said about the diaphragm. The diaphragm only is a one muscle. It doesn't have antagonists, but generally all the others have antagonists. And so if we're stuck in one position, say we've got those tight pecs, we know that the retractors, the traps in the back, are going to be loose and weak. And so if we can stretch the tight pecs, we can work the loose and weak mid traps, for example, and get them to be a little bit more active. Secondly, as we age, we all get stiffer. We lose water from our cartilage, from all our tissue. We get stiffer and tighter. That's why, again, it's the older people we should be seeing in the gyms, not the young and beautiful ones. And so as we age, we need to stretch more. Stretching is a natural activity. Most animals with movement, insects, mammals, we all stretch. But be careful when you're stretching. You want to make sure that you're stretching the right structures specifically. Are we stretching passive structures like joints and tendons? Well, ligaments, I should say. Or are we stretching active structures like muscles and tendons? Because we know the way you stretch those two different structures are different. And so make sure that when you're explaining what stretches are necessary to your patients, you're giving them the right stretch, because you know it's the joint in this place and it's the muscle in that place. It isn't always the same. We want to use the stretching to reduce muscle tension in those tight places. And the pain comes from using tight muscles. We want to use the stretching not only to increase the range of motion, but also enhance muscular coordination. If you're in a tight place, especially if you're somebody with spinal cord injury and you also have hypertonicity, your muscular coordination is not going to be the best if you are in a tight place. And so stretching and maintaining flexibility will also help with coordination. And we'll be talking about skin stretching. The skin is the one underappreciated aspect of mobility, because if our skin is tight, the most extreme case you could think of would be, say, keloids. But if somebody, say, at that C6 level, you know, they're kind of up here. C5 is notorious for being like this, but people at C6 can get like keloid also because they don't have the C7 to overwork the biceps, right? That notch, the notch here is going to be really, really tight when you start to do any kind of stretching. So making sure you really stretch out the skin of the elbow, the antecubital fossa here is really important. In the lower extremities, in the back, the popliteal fossa can get tight. Even parts of the scapular area can get tight. And certainly, if you want to look at stiffness of the thoracic cage, try doing a little bit of skin pulling on the thoracic skin, on the skin over the thoracic cage. You'll appreciate how tight thoracic skin can. So we'll be talking briefly about that in a second also. When you're doing any kind of stretching activities, as I've been saying, you want to know what's going on with the range of motion. Okay, is it joint tightness? Is it muscle tightness? You should be able to discern those two. Check the hypertonicity, because if that place is very, very spastic, then you need to take care of not only the physical aspects of the tightness, but also the neurological aspects of the tightness. Does their baclofen need to be pumped up? You know, are they willing to use Botox to help reduce some of that hypertonia? Do we have electrical stimulation available for them to use to reduce hypertonia? We also need to assess their proprioception and kinesthetic awareness. Why? Because if they're going to be standing, say you're giving them a standing position at home and they have no proprioception of their ankle, they need to understand that so they can visualize their ankle so that they know they're properly aligned. For people with dysreflexia, that might be the cause of their dysreflexia. So making sure that when you're helping people to stretch, they know when to say enough, or you have an idea of when you are going to say this is enough for you. It may not be based on their sensation themselves. I mentioned skin tightness. And lastly, if you're going to start and do a stretching program, you absolutely do want to make sure that there are methodologies in place to limit and or hopefully prevent the onset and the return of the tightness. We know that passive stretching tightness is generally only a temporary thing. It's not a bad reason to do it, but we know that we need to keep on doing it. You know, just because you need to brush your teeth tomorrow doesn't mean that you shouldn't bother brushing them today. So stretching is always useful. So find those methodologies as best as possible, whether or not it's teaching caregivers, teaching that person to teach other caregivers and so on. It's really, really important. And static stretching is always easy to teach people. Most people are comfortable with their static stretches. The passive static stretch is the most commonly used one. And if you're talking about, say, trunk rotation, you know, the passive static stretch is I'm going to take myself into a tight position and then I relax, but I hold the stretch for 20 to 30 seconds. It's passive, but I'm in the stretch. An active stretch, though, is same idea. I take myself into the stretch, but during the 20 or 30 seconds of the stretch, I'm actively pulling myself into the stretch. So the muscles stay on and continue the rotation. I like a good isometric or PNF stretch because it engages and works the nerves of those muscles, the antagonist and agonist, against each other. And so if we're talking about rotation again and say my antagonists are taking me into a tightness here, when I get into that tightness, I'm going to have somebody resist my return. So I work the agonists, somebody resists me as I try to turn into the antagonist, but I'm not moving. And this is the principle it works on. If your agonist is active, the antagonist has to be inhibited. And so by turning on the antagonist of where I want to stretch, I relax those agonists, and then I can stretch them some more. So it's a really great way of relaxing the muscle you actually want to stretch. And it is wonderful for hypertonia because that neurological structure can often still be reflexively in place. And so use them with your people with spinal cord deliberately. We have a lot of stretches we could do, but I just have a few videos of some of the main ones I usually do. Back to angel, and this is a sort of trio of the ones which I believe are generally overlooked. We need to work the rotation for people with spinal cord injury. They miss this so much and they don't get it enough. And the more we can work rotation, the more I think we can limit the onset of scoliosis because we can derotate them out of scoliotic changes rather than leaving them in one direction. We also definitely want to stretch the whole thoracic cage, and we do that with the arms first, assuming that we can get some good stretch. I encourage you to use the arms in an external rotation and supinated position because most of people's spinal cord's life is internal rotated and adducted. And so get them nice and open. And if there are any OTs in the house, you will see this as basically just dealing IYTs, the T and the I. And again, because a lot of people with spinal cord injury do not get up here. And so we want to encourage them to get all those actions of movement. Sorry, this one. Next. And now, side bend, because again, a lot of action takes place forwards and backwards. We can often get there with our patients, and even standing is a sagittal action. But we want to do side bending because again, like rotation, it can really help with scoliotic changes and mobility and strengthening of the rib cage and the lumbar spine. However, the problem is this, your spine is not one unit. And so it's often that when I see people stretching, they really stretching the parts that are already loose because the tight parts stay tight because we cannot with your normal just fall over stretch. You can't isolate where the stretch goes. But with the spinal mobility belting technique that you see here, I'm isolating the stretch firstly here at the lumbar spine, because we got the belt just on his pelvis. And so when Angel leans over, you can see when I push on his arm, in this case, I can push on his rib cage, which I'm now going to, you can see that he's really, the stretch is going into the lumbar spine, into the abdominals and into the quadratus. That's where the stretch is really going, because the belt is the fulcrum on which the stretch occurs. All right? And so by bringing now the belt into a higher place, I brought the belt higher on myself as well, as you can see, just to protect my back. And so by bringing the belt higher on Angel here, and when we do the stretch, you can see now, again, the belt is the fulcrum of the stretch, and it's a very different stretch. I'm really now stretching the thoracic cage, not his lumbar spine or his abdominals or those muscles, okay? And so the belting technique really is useful to help isolate and segmentalize where mobility gets put into the body. You can do this from the front as well. So say for somebody who's being really kyphotic, I can position the belt at T11, I can bring it up to T6. I can't bring it up much higher than T6. Why? Because the scapula is in place. But you can certainly get to work segmentally using the technique and using the belt. And you can also use pulleys. I love using pulleys. Just pull the standing frame up to a door setup, or if the person can have a door set up in their home, you can stretch the arms and the whole shoulder girdle, including the scapular girdle, in all kinds of directions. And it's so easy to do. And it is active rather than this passive, oh, stretch me, please, kind of thing. It gets them to do the work. I finally will mention dynamic stretching, full body warm up. So even if it's just throw and catch, you know, you can make people throw and catch in different places, throw and catch a little higher than you would, go a little lower, get them to use their whole body as they warm up in the frame, okay? Improves their kinesthetic awareness so they kind of get an idea of how far they can go. Absolutely will improve their flexibility. And myofascial release is the tool to use for skin stretching. I mean, there are other tools in terms of cupping and in terms of, what else not to use, rollers. Are also tools that can be used for myofascial release. But really get your hands in there, do a little fascial skin rolling, really see what the tightness of the skin is, and teach people or caregivers how to do this, because it's the one component, again, that I tend to see we underappreciate in terms of how much tightness can sit within the skin itself. I think we are there. So let us conclude and put all the take-home messages in one place. Standing is great for people with spinal cord injury and helps them not only improve their range of motion, it helps with all these cardiac and pulmonary functional activities as well. Definitely everybody should be standing, especially with spinal cord injury. The respiratory interventions do benefit people with spinal cord injury to help maximize all of their pulmonary function. We know what we can do. We have the tools, we have the techniques to help people with spinal cord injury improve their respiration. And if you can put respiration and standing together, you've doubled, I would say even increased more than double the benefit of those activities in standing. We have those tools, like the breathing activities, like the resistance trainer, like the flexibility and strengthening activities that we can do for the whole shoulder girdle, upper extremity, thoracic cage, and also the lumbar and abdominal sections. We can put work into all of those components to help them maximize all of the respiratory function of all of the tissue and help people with spinal cord injury maximize their function by having better respiration. I thank you all for attending, and I look forward to all the questions that you have. Please, thank you, Marianne. That's information about us.